So it's my great pleasure today to welcome you to NAPCAN's Thursday webinar, the fourth in the National Child Protection Week 2022 series. My name's Rani Kumar. I'm the Head of Policy and Campaigns at NAPCAN, and I've been given the honour and responsibility today to guide you through a very important conversation about Australia's first study on the prevalence of child maltreatment, with some preliminary results being shared with us today. But I'd like to start by acknowledging and paying my respects to the Gadigal people of the Eora Nation, the traditional custodians of the land from which I'm speaking to you today. I'm in Sydney in the Inner West. I'd like to pay my respects to elders past, present and emerging, and I'd like to acknowledge all of the elders past, present and emerging from all the lands from which you're joining us today, and to pay my respects to any Aboriginal and Torres Strait Islander colleagues who are logged on today with us. If you're not familiar with GoToWebinar, so just a little bit of housekeeping, the control panel's on the right-hand side of your screen, most likely. And if you run into any technical issues, please contact our team whose details are in the chat function. Just reach out and they'll be able to help you with whatever you're having difficulties with. In the control panel, you'll also see a questions function at the bottom. We have hundreds of people online with us today, so that's fantastic, but we're really keen to hear from all of you. We want this to be an interactive discussion. We want to know what you're thinking and what you want to understand better about the research that's being shared. So please keep sharing questions with us throughout the session. Don't wait till the end. You can shoot them through at any time. Relevant handouts and links are also in the chat function that the NAPCAN team will be putting in there. And just so you know, the webinar is being recorded and will be emailed to you, anyone who's been registered, but also posted on NAPCAN's website. So we're here today on RUOK Day together as part of National Child Protection Week. It's my great privilege to be the lead of National Child Protection Week at NAPCAN, and every year our aim is to utilise these webinars for really fresh and deep conversations about what's new and inspiring, and helps us better understand how we create safe and supported communities for children. So I hope you know by now that National Child Protection Week is continuing to embrace the overarching message that every child in every community needs a fair go. That's the core message we want everyone to understand and come along with. And these conversations obviously don't end this week. You know, Child Protection Week is just an opportunity to elevate the issue of children's safety and wellbeing in Australia to a wider community discussion. And we need to have these conversations about what we as a society need to do to make sure that every child in every community has the opportunity to thrive. But obviously that work goes on year round, and I thank all of you for the contributions that you make to making this possible. We also know collectively that too many children are not growing up safe and supported, and that child protection systems are overloaded. So we know together that there are opportunities to change the trajectory for these children. We can stop child abuse and neglect and reduce its impact by working together and putting children and young people at the centre of that work. And that's what today's conversation is really about how can we use research and data to help us map the experience of children and young people who experience abuse and neglect, and then work out better ways to prevent this. What are the best ways to prevent it? Or refine the best ways to respond in a therapeutic way so that every child in every community can have a fair go now and into the future. So just before I introduce our fantastic expert presenters and get into the discussion about the research, I just want to highlight, bring to your attention that some of the topics that we cover today are, maybe a bit sensitive or upsetting for some of you, because we will be talking about neglect and exposure to domestic violence, for example. So if you need to take care of yourself, you need to step away from the webinar for a little bit or mute us and come back after, having a little walk or a little break, please do that. Please do take care of yourself. Our team have also posted some contact details of services and helplines in the chat. So if you need to reach out for some support, please do that. Particularly important today on RUOK Day. Okay, so while the larger prevalence study will be released early next year, hopefully around March, we are lucky enough today to get some selected preliminary results shared with us, like I said, including a deeper discussion of neglect and exposure to domestic violence and what that means to young people and the impacts on them. So we're very fortunate to have with us today Professor Ben Matthews from QUT, who's the lead investigator on this study, Professor Daryl Higgins, another investigator on the study and the director of the Institute of Child Protection Studies at ACU, and Dr. Deebna Haslam, the project manager on this study and senior research fellow and clinical psychologist at QUT as well. They're going to guide us through these preliminary results and the implications. How do we apply this data? So now I'd like to introduce Ben Matthews to kick off the presentation and get us started for the discussion later. Keep sending your questions through. Thanks, Ben.
Thanks so much, Rani, and thanks to NatCan for inviting us to talk today during Child Protection Week to this large audience of really key stakeholders. We're absolutely delighted to have this chance to talk with you, and we look forward to further presentations to you and discussions with you next year. So we'll have just a boom year next year to engage with you and learn from you, but also to share our key findings with you. Every so often during this first 10 minutes, and indeed our whole presentation, you'll hear us say thanks to Nadia, and that's a signal to Nadia to move to the next slide. Thank you very much, Nadia, for helping us with this today. If you could move to the next slide, thanks, Nadia. So as with all of our presentations, these are really given on behalf of our entire team. It's a very large team, as befits this large study. So we have 10 chief investigators. We also have Dr. Deebna Haslam, who's here with us today, and she's our project manager as well, obviously as a very well-renowned scientist in her own right, and our statistician, Dr. Eva Malakova. Thank you, Nadia. And I would like to acknowledge country as well, acknowledge the traditional custodians of the lands on which we all meet together, and pay my respects to their elders past, present and future. And here we're coming to you today from Turrbal and Yagara country here from QUT. Thanks, Nadia. So today we'll be giving a bit of a background about the study. So first I'll spend about 10 minutes talking all about the ACMS, then we'll pass over to Deebna and Daryl to talk about some of the key components that we've measured in this important national study, and we'll come back to me to wrap it all together, and we'll make sure that we have a good at least 20 minutes or so for questions and answers. There's obviously an awful lot that we can discuss about this project, and we're keen to engage with you and ask any key questions that you have. Just to reiterate before I get into the content, we do have our major findings now from this 5-year national study. We're in the 4th year of this 5-year study. We are, in fact, slightly ahead of schedule, we're happy to say. So we've completed our survey. I'll come back to that shortly, but we've completed our national survey and we've analysed the key results to generate the major findings about the prevalence of child abuse and neglect in Australia and their key associated mental health outcomes and health risk behaviour outcomes. And those scholarly journal articles are under review right now. So we're very excited to have generated those findings. They're quite sobering findings, but it's our responsibility, I think, as scientists and as stakeholders and practitioners in this field to then take them to policymakers so that our findings can inform better prevention and policy in future. That's the reason why we've done this study. So we're really happy to start this preliminary conversation with you all today. We're really looking forward next year to giving you even more information about our findings. But today we see it as a great opportunity to share with you what we've done, why we've done it, and to give you an advanced indication of some of the types of findings that we've generated. Thanks, Nadia. So just a minute to give you some background about why we've done this study. So why was this Australian Child Maltreatment Study needed? And look, the basis for this is that until now we have had, as a country, no reliable evidence at the population level about three things. And we need evidence about these three things to better prevent child maltreatment. So we have no reliable evidence about the prevalence of each type of child maltreatment. And when we talk about child maltreatment, we're talking about 5 types: physical abuse, sexual abuse, emotional abuse, neglect, and exposure to domestic violence. And so for now, until our articles are published, that is, we have no reliable evidence, for example, about the percentage of the population that have experienced each of these types of maltreatment, nor do we know the proportion of the population that have experienced multiple types of those and which types. So that's a massive gap in evidence, a massive gap in fundamental knowledge that we need as a country to better prevent and respond to child maltreatment. The second area that we lack scientific evidence about is the characteristics of those types of abuse and neglect. So for example, how old are kids when these types of abuse and neglect begin and end? What are the different trends by sex and gender? Which specific subtypes of those child maltreatment types occur most often? And just as importantly, which are most harmful to children, both in adolescence and in later life? We also don't know who is it who inflicts these different types of maltreatment the most. And obviously you can see already that generating this picture, this comprehensive, nuanced picture of the phenomenon of child maltreatment will give us the type of evidence base we need to better target our public health prevention responses. The third big domain of evidence that we haven't yet got is what are the associated mental disorders, physical health outcomes, and health risk behaviours that are consequent on child maltreatment. And so as a whole, this is what this study has done. We've generated this evidence for the first time, and we hope that it will help to guide future prevention policy. Thanks, Nadia. So the reason why we did this was to generate this evidence to inform better approaches to prevent child abuse and neglect, and as a consequence to reduce the associated health conditions and health risk behaviours that abuse and neglect causes, and also to reduce economic cost to the nation. And obviously, as befits the audience today, which comes from multiple sectors, these findings have significant implications for multiple stakeholder groups and practitioners who serve children and who serve parents and families and communities as a whole. So obviously, some of the key ones are early childhood education and care, primary and secondary education sectors, child protection, family welfare and well-being sectors, and out-of-home care sectors, and also at a broader level, health sectors and even departments of justice should find these findings about the prevalence and outcomes of child maltreatment incredibly important in terms of informing their approaches to different levels of prevention of and response to maltreatment using a public health model. Thanks, Nadia. So in terms of what the ACMS has done, we've conducted the first comprehensive nationwide study of the prevalence of each type of maltreatment, characteristics of those experiences, the key health outcomes through the lifespan of those experiences, and the burden of disease from maltreatment. Thanks again, Nadia. In a nice, quick graphical form, here's what we've done. First prevalence study of maltreatment in Australia. We've interviewed 8,500 people aged 16 right through to age 65 plus. We've assessed the prevalence and consequences of each of those 5 types of maltreatment that I mentioned before. We've measured 2 broad domains of health outcomes, physical health and mental health. And incidentally, we've also measured health risk behaviours, things like self-harm, suicide attempts, smoking and cannabis dependence. We've also identified or will identify the burden of disease to assess economic costs. And again, we have done this obviously to produce rigorous, reliable scientific findings, but ultimately the motivation of our entire team to do this study is not just to write journal articles and reports, it's to engage with stakeholders and groups, to take our findings to them so that they can inform future policy and practice to better prevent and respond to child maltreatment in future. Thanks again, Nadia. A couple of key points about the study. It was a nationwide survey, 8,500 participants. Of those, 3,500 were aged 16 to 24. We did that to generate particularly powerful evidence about the relatively recent experience of maltreatment in Australian society. Then we have 1,000 participants each in those 5 age decades mentioned there, right through to 65 plus. Key reason for doing that is so that we can assess health outcomes of child maltreatment right over time through the life course. We can also, by virtue of having surveyed those older Australians, we can also compare current prevalence rates of the younger group, aged 16 to 24, with rates of maltreatment from further back in time in Australian society. We conducted the survey by, it's called computer-assisted telephone interview, but basically a mobile phone survey where people gave self-reported information about their experiences in childhood. And this entire survey, this entire project adopted the standards of best international practice. So there was an awful lot of preparatory work that we conducted to inform our approach to this large national survey. And one of the key bits of preparatory work we did was a global systematic review of all national studies of the prevalence of child maltreatment that have ever been done around the world of 4 or 5 types of maltreatment. And we then critically analysed those to figure out the best way to do this study in Australia. Thank you again, Nadia. A really important point just to note very quickly is that our survey involves a random sample of the Australian population. And that's really important so that our sample is not biased. And essentially what that means is that we've got rigorous evidence of the actual proportion of the Australian population who experienced all of these types of child maltreatment in their childhood right up to age 18. And that sample was representative of the entire nation, so across all states and territories. Thanks again, Nadia. I'll just take a minute or so on each of the next 4 slides just to slow down for a moment. I'll just let you know that we spent the first 2 years of this 5-year study. So we commenced in 2019, and we spent the first 2 years on a really patient, careful, rigorous development process and testing process in terms of the design of our survey instrument. And so we took what we found was the best survey instrument that's been used around the world, which is called the JVQ for short, the Juvenile Victimization Questionnaire. And we adapted that for use in this study. And in some senses, we enhanced it. We made it even better for some of our purposes. And one of our chief investigators, David Finkelhor, is American, and he was the lead co-author of that original JVQ, and he's been incredibly generous and fantastic to work with on our team. And so he has played a huge role, as have all our team members, in adapting and testing our survey instrument. And it's quite an extensive instrument, and it's gone through a very rigorous testing process, including cognitive testing, conceptual testing, and then a full pilot. So it was a very careful, rigorous process. And the survey instrument assesses a whole range of experiences, obviously focuses on the 5 types of maltreatment, and I'll talk a little bit about those right now. Thank you very much, Nadia. So, one of the really important things to do when any survey is trying to establish the true prevalence of maltreatment is to assess each of the 5 types and to assess them with sufficient depth. And what we're really referring to here is you can't just ask one question about any of these 5 types of maltreatment to determine its true prevalence. What we did through our careful process of developing the survey instrument was to figure out the best questions to ask about each of these 5 types of maltreatment to generate reliable evidence about their prevalence. So we ended up with 20 questions, including 3 on physical abuse. So there were 2 specifically on different extensive physical abuse and 1 on corporal punishment. 7 questions on sexual abuse, which included 2 on internet sexual victimization, 3 on emotional abuse, 3 on neglect, and 4 on exposure to domestic violence. So as a whole, the answers to those questions in the survey, and each question had a yes or no response, the answers to those give us the prevalence data about each of those types of maltreatment. So they give us the prevalence data in terms of the percentage of the population that's experienced each of those 5 types of maltreatment. Thank you again, Nadia. We asked follow-up questions, and basically this gives us really rich contextual information about the characteristics of that maltreatment. And this is important because while it's important to know how prevalent maltreatment it is, we also need to know where can we target our efforts best. And so we need to know more than just how prevalent it is, we need to know some of the characteristics. So we asked how many times did it happen? We also asked how old was the child when it began and ended. We asked who were all the people who did the particular acts that they experienced. And in the sense of physical abuse and sexual abuse, we asked if they had ever disclosed those experiences. If so, how old were they? Who did they disclose to? And did they feel supported when they disclosed? Thanks again, Nadia. So in sum, just to let you know where we're at and what stages of progress we've gone through and what's coming next. As I mentioned, we spent the first 2 years doing an awful lot of preparatory and testing work. We actually completed the conduct of the survey last year, despite a little thing that happened called COVID-19. We and our partner, the Social Research Centre, managed to stay on track and completed the survey over a 6-month period, April through October. 8,503 people ended up being surveyed. In case you're curious, each survey took on average close to half an hour, so it was quite an extensive survey. Along the way, we've published some quite important articles on our methodology. So we've published a protocol article which explains what we've done. We published an article about the ethics of conducting this survey and the approaches adopted to make sure it was done ethically and to minimize participant distress. We also published a paper about our legal compliance and taking care of participant safety and preventing and responding to risk of harm. Right now, the third kind of column in that graphic, we have our 7 main articles that are under review at a journal. The findings are embargoed because of that, but as soon as we can, we want to let you know about that. We anticipate that we should be able to have our public release of results in March 2023. We can share with you today some of the kind of related connected findings, and that will give you a taste, a flavour of the some of the types of things we've found. And along the way, we have commenced an accelerated engagement, especially with government agencies, but also with some NGOs, just to prepare the groundwork for hopefully the employment of our findings to inform future policy development for prevention. There will be a lot more findings and analyses done, particularly of, say, high risk categories, and that will continue through the rest of this year and through next year and likely several years afterwards. So there'll be a lot more things coming out of this study that will have particular significance for particular stakeholders, and so we'll keep you apprised of all of those developments. The study itself is funded until the end of next year, but there will be a lot of work happening over the next 1, 2, 3, 4 years. Thank you, Nadia. There's our papers there. You can access those on our website. And Nadia, we can go straight to the next slide. Thanks. And I can mention to you all that every output that we have produced and will produce from this study is made available on our website. You can all, please do feel free to access that. I can let you know that all of our key journal articles that present our main findings have already been made open access, and all of our future main articles will also be made open access. So they'll be freely available for you to obtain and indeed to share. So that's a really important practice that we wanted to adopt to make sure that our findings are not just holed up behind firewalls. Also, through our website, if you wish, you can sign up to our mailing list, and that's where we also put up news updates as well. Thank you, Nadia. So just wanting to keep to time, this is my last slide before I pass over to Divna. But obviously, our findings have massive implications for governments, for social systems, and for various stakeholders. We want to have, in due course, we want to have these findings influence prevention and early intervention and better trauma-informed responses to different types of maltreatment that are identified. And again, we acknowledge and we're delighted that you're all attending today and showing your interest in this. And so we want to continue engaging with stakeholders and authorising agencies at the national level and at state levels, and we will continue to do that and keep you informed of those engagement efforts. So I'll return a little bit in the last section of today's presentation to the significance of the findings and what will happen next. For now, though, I will pass over to Divna, Dr. Haslam, who will talk about neglect. And thank you, Nadia.
Hi, thank you, Ben, for that excellent overview of the whole ACMS project. So I'm going to be talking a little bit about what neglect is and how it's related to mental health, and in particular, major depressive disorder. So it's kind of a deep dive into the first impact of neglect and how that impacts mental health over the course of the lifespan. So Nadia, if you wouldn't mind the next slide. So first of all, what is neglect? Really, it's a failure of the parent or caregiver to provide the child with the basic necessities of life related to their developmental stage and as recognised by the child's context. So if we put that in plain language, it's really about ensuring that all children are given a fair go. All children have the right to be safe and supported. All children have the right to an environment that's safe, predictable, and loving and interesting for them. Next slide. But unfortunately, many children do not have that opportunity. And so these are the children that are exposed to different types of neglect. And when we think about neglect, there's kind of a number of different categories of neglect, but they all kind of tie into the same thing, that the child isn't given the environment, love and attention and nutrition and so forth that they need. So there are 5 kind of key types that we talk about here. Environmental neglect, so living in an environment that's unsafe or unsanitary. Physical neglect, where we're looking at children not being given the nutrition that they need or the care and affection that they need. So of course, when we're thinking about providing children with a safe environment, that's both safe emotionally, but also safe physically. Medical neglect, so not getting the environment, not living in an environment where they're actually getting medical care, dental surgery, dental checkups, other medical needs. Educational neglect, so some children just don't have the opportunity to go to school. In some areas, children are encouraged to stay home so they can help with other siblings and things like that. And supervisory neglect, where children are kind of left on their own and not given the appropriate supervision given their age. So I guess if we're thinking about it, really, it's about making sure that all parents have the opportunity to provide all of these with children. And any of you that are parents here, like I am, will know that it's not possible to always supervise your child. It's not possible to always be physically affectionate and provide a perfect home for them. So we're not talking about kind of minor levels of neglect. We're talking about overall patterns. So next slide, please, Nadia. And really, we're thinking about neglect as a spectrum. So conceptually, really, for neglect to be occurring, it has to occur over a period of time. So in the ACMS, we've looked at that from a couple of days up to a couple of weeks through to a couple of years, or perhaps throughout the entire childhood. And it's not as simple as saying either children experience neglect or they don't. Many children will go kind of in and out of neglect periods through their life. So on one side of this spectrum, we've got kind of minor non-harmful neglect that's caused primarily by poverty. That might be short-term or it might be more long-term throughout the period of childhood. And then on the other end of the spectrum, on the higher end, we have the cases that you hear about on the news. So these are the children that are in life-threatening neglect. They often are tied up or don't have access to any food or hygiene, or are undernourished and things like that. And all of those kind of life-threatening neglect are caused by multiple factors. So it's not as simple as just addressing poverty. We actually need to take whole systemic approaches. We need to make sure that children and families have appropriate support, that have economic stability, that parents' mental health and physical health are looked after, so that they're able to then look after their own children. And then, as well as this kind of spectrum, children might move in and out of periods of neglect throughout the course of childhood. So there may be some periods perhaps early on where they're exposed to some neglect, and then other periods where they're actually having a loving, safe, predictable family environment. And so, of course, with out-of-home care, we're hoping that we can remove children that are in extreme life-threatening situations and put them in an environment where they're safe and supported. Next slide, please, Nadia. And I'm talking just about neglect today, but I just wanted to highlight that neglect doesn't occur in a vacuum. So Ben has highlighted the kind of 5 different types of childhood maltreatment, and it's not really possible to separate out the influences of neglect without these other types of maltreatment. So in practical terms, many of the children that are neglected are also experiencing some of these sexual, physical, emotional abuse or exposure to domestic violence. So we have to kind of take a comprehensive view of what the child's environment is actually like and how that might be making a difference. Next slide, please, Nadia. So now I'm going to transition a little bit to why neglect might be associated with mental health, and in particular clinical depression, which is what I'll be talking about today. So we know that early exposure in life to trauma and early exposure to positive environments has an influence over children throughout the course of their life. So it impacts them not only in childhood, but all the way through their life. So physiological changes occur in childhood, brain development changes occur in childhood. Social connection patterns are established very early on. So children learn a lot from their environment and the way that their parents and family interact with them about their own sense of self-worth, about whether they're valued to other people, whether they deserve an education, whether they deserve an environment that ensures every opportunity for their success or not. And over the course of that, that impacts, of course, their education and future life earnings and things like that. So in the ACMS, what we're interested in is, does exposure to childhood neglect predict clinical levels of depression? So in this data that I'm presenting now, we're just looking at the young people's data from 16 to 24, and we're only looking at clinical depression, so major depressive disorder. What that means is this is a really, really conservative effort. So if we were looking at just depressive symptomatology, like many studies do, we would probably find even bigger effects than I'm going to present to you now. So all the way as I'm presenting things to you, remember these are clinically diagnosable psychiatric conditions, and that many people will actually live with levels of depression or depressive symptomatology that's sub-threshold below that kind of clinical cutoff. So the questions I'm here to answer today is, does neglect actually predict clinical depression? Does the type of neglect matter? So in the ACMS, we're assessing environmental neglect, physical neglect, and medical neglect. And for the purposes of this study, we've assessed neglect as occurring over at least a period of weeks. So if a parent was perhaps having some kind of emotional situation, there was a period of days where they were perhaps a little bit neglectful, we're not really assessing that. We're really talking about neglect that's occurred for at least a couple of weeks. We're interested in, does sex matter? So do boys and girls experience things differently? And does the overlap with other types of childhood maltreatment make any difference? So if I was here in front of you live today, I would ask you to raise your hands and tell me how many of you think that neglect in some capacity will predict clinical depression. So I can't do that, but I would imagine that most of you would have your hands up, because we know that early childhood exposure to adversity has an impact on long-term mental health. However, I can't do that, so I'm going to jump ahead to the answer. Nadia, next slide, please. And confirm that, yes, neglect does predict depression. What we found in our study of young people, 3,500 across Australia, is that for both girls and boys, or males and females, the experience of childhood neglect did predict major depressive disorder. So this is criteria, medical, psychiatric conditions, not just low-level symptomatology. And in females, we found that girls that had experienced any of those types of neglect combined were 1.5 times more likely to actually meet criteria for a major depressive disorder. When we look at males, males have even more relationship between early neglect and major depressive disorder. So males are 2.6 times more likely. Now, of course, this just looks at neglect in general and depression. That doesn't take into account the fact that there are other types of child maltreatment that might be playing a role. So what I'm going to do now is I'm going to look at things in a little bit more detail, look at what the influence of different types of neglect are, but it's while we're controlling or adjusting for other types of maltreatment. So this is the patterns when we actually look at, did the child also experience other types of sexual abuse, emotional abuse? So these are the kind of pure effects, if you will, of neglect. Next slide, please, Nadia. And here what we find is that it's a much more complex pattern. So when we control for other types of child maltreatment, the relationship for girls or females and major depression actually drops off. So that tells us that it's not just the exposure of these girls to neglect, it's actually the exposure of neglect plus the other things that they're experiencing in the family environment. So we don't see that relationship. So once we adjust for other types of child maltreatment that the girl has also experienced, we don't see that pattern anymore. But for males, we do see that pattern. So next slide, please, Nadia. For males, even when you control for other types of abuse or exposure to domestic violence that this male child might have experienced, they are still 1.9 times more likely to experience a major depressive disorder. This is not just I'm feeling a bit depressed or I'm struggling with mood. This is meeting threshold for a psychiatric disorder. So that tells us that neglect has a huge impact on male children far beyond childhood. So this is for data up to 24-year-olds. And I would imagine if we looked at this for even more older children and as you go through the lifespan, we'd see an even stronger effect. Next slide, please. So let's look at the patterns of the different types of neglect. So when we look at environmental neglect, so this is the children that aren't given the opportunity to live in a safe, sanitary, hygienic environment, girls actually have the bigger risk factor here. So girls that have exposure to childhood environmental neglect are 1.7 times more likely to report a major depressive disorder by the time that they're 24 years old. For boys experiencing neglect, we didn't see that same pattern. So we know that there are some gender differences. Next slide, please, Nadia. When we then look at medical neglect, we see the opposite pattern. So here, the boys are 2.2 times more likely to experience major depression than the girls. We actually are not seeing any relationship between medical neglect and depression. So clearly there's something going on where exposure to neglect in general is harmful. It's worse probably when they're experiencing other types of childhood maltreatment, but there are also gender differences that we need to take into account for. Finally, Nadia, next slide. And when we look at physical neglect, actually neither gender is at greater risk after you control for other types of maltreatment. So remember I put up that slide in the beginning with all of the 4 types of child maltreatment plus neglect on the other side. This is why we're seeing that some of the patterns of neglect don't show up, because it's occurring in the context of lots of other things. And we'll be able to present early next year the data on how many children experience neglect and different types of childhood maltreatment and how they overlap. So next slide, please. So what does this mean? We know that neglect does predict major depressive disorder. It certainly has a huge impact, and it's a risk factor for subsequent mental health, particularly depression, but also the ACMS assesses post-traumatic stress disorder, generalised anxiety disorder, and a number of other factors. We know that general neglect does have an influence for both boys and girls experiencing neglect, but also that it's not a simple relationship, it's actually more complex, and it's related to what other experiences these children are exposed to. So if they are also experiencing physical abuse, emotional abuse, sexual abuse, and exposure to domestic violence, probably the risks are far worse, and we'll be presenting on that next year. Next slide, please. So let me go back to the aims. What did I say I was going to present, and what are the takeaway findings? So does neglect predict major depressive disorder in young people? Yes, there certainly are very clear associations. That tells us that we need to do something about neglect. We need to actually make sure that government and practice can intervene to ensure children do have that opportunity to be safe and supported and to be given a clear environment where they're loved and have appropriate nutrition, care and attention. Does the type of neglect matter? Yes, there are differences in the different types of neglect, and sex matters as well. So overall, boys seem to be at greater risk for mental health outcomes in terms of major depressive disorder compared to girls, but girls also do have that relationship. And finally, does childhood maltreatment matter? Yeah, of course it does. So the children that are exposed to more types of childhood maltreatment are more likely to have more severe levels of, or more likely to have clinical levels of major depressive disorder. Next slide, please. So what do we do with this information? It means that we need to intervene early. It means the impact of abuse and particularly neglect doesn't stop when their child is removed from that environment. So there's a lot of focus on child protection. Absolutely, we need to get these children into safe and supportive environments where they are loved and cared for. But doing that is not necessarily going to fix the trauma and associated adversities that they've experienced in the past. We still need to kind of be thinking about these as risk factors throughout young people's lives and perhaps also throughout the course of their adulthood. We need to be thinking about screening for depression. If we know children have experienced different types of childhood maltreatment, in particular neglect, we need to be screening for depression, doing thorough assessments, and also thinking about this at a subclinical level. So I said at the beginning, these data are just based on clinical criteria for major depressive disorder, and there are far more people that experience low levels of depression that don't meet that criteria. So we absolutely need to target neglect to reduce depression and to improve outcomes in children in general. Next slide, please, Nadia. But reducing neglect on its own is not enough. We really need to target all types of abuse to impact the lives of children and to create real change. And that's where Child Protection Week really comes to the fore. So thank you for this presentation. I'll pass on to Daryl now. Thank you, Daryl. He's going to be talking about exposure to domestic violence.
Fantastic. Thanks, Deevna. I'm really excited to be delivering the next part of our webinar, talking about the relationship between exposure to domestic violence and its impacts on mental health with findings from the ACMS. Thanks, Nadia. So what is exposure to domestic violence? As Ben has already outlined, exposure to domestic violence is one of the 5 types of child maltreatment that are generally recognised by researchers globally, and is one of the 5 types that we have focused on with the ACMS study. Exposure to domestic violence can be traumatising, even if a child is not physically harmed. In other words, if they're not the target, if you like, of an abuser or a perpetrator's actions within a domestic context, they are still seeing the acts of harm to, it could be to a mother or another sibling or another person present in the household, and they are experiencing the consequences of that, often the fear and the anxiety that goes on in those homes where domestic violence is prevalent. We know that it's likely to be more common than expected, and certainly that's part of the role of our study, is to look at exactly how frequently adults describe having experienced exposure to domestic violence during their childhood up to age 18. And as Deevna has already reflected in relation to the results that we've shared around neglect, we know that it's likely that exposure to domestic violence isn't something that happens on its own, but it may happen in the context of exposure to other forms of abuse or neglect of children. And so we're going to be looking at all of those things in this study. Next slide, thanks, Nadia. So we can see here the definition that we've adopted is that exposure to domestic violence is occurring when a child witnesses acts of violence done towards other family members in the home when they were a child. So witnessing can occur by either seeing or hearing the acts occurring. And those acts are typically done by and between parents and caregivers. And it may or may not cause direct harm to the person, to that child or to their parent or the person who's the direct recipient of the violence. But we're interested in tracking in the long term into adulthood, whether that exposure, seeing or hearing those acts of violence within the home have an impact, and the nature of those impacts. Thanks, Nadia. So our operational examples, what do we mean by that? So often when we hear about domestic violence, and certainly the exposure that the topic has within the broader media per se, often the image that we have in our mind is of physical violence. So, you know, between a husband and a wife, or between, you know, two intimate partners, we often think of physical abuse as being the form of domestic violence that is typical. Yet when we look at the literature, we know that it can occur across a range of different domains. And you can see on this slide illustrated that it can be physical, it could also be sexual, or it could be emotional in ways such as coercive behaviours. So that could be around asking somebody or forcing somebody to do something that they don't want to. It could even relate to domains such as cutting off people's friendships and not allowing them access to, you know, to finances, etc. Or it could be about overt threats, so threats of harming somebody, and often physical violence towards inanimate objects in the home. You know, banging a wall or hurting pets is often a very typical part of exposure to domestic violence. And so we're looking at that full range of experiences. On the next slide, though, we can see, as Deevna illustrated with neglect, that exposure to domestic violence isn't a categorical thing. It's something that exists on a spectrum. So we know at the lower end of severity, it may be a single, relatively minor incident where a child is growing up in a relatively stable, loving environment. And those kind of experiences where they're one-off, and less severe, we know that they're less likely to have serious impacts either on the child in the short term or long term into adulthood. Whereas right up the other end of the spectrum, we know that many children are experiencing violence within the home on a daily basis, where the environment overall is characterised as typically violent and unstable, and where there's evidence of harm to children right from the get-go, that those are the ones that are most likely to lead to more severe outcomes during adulthood. But we know that, of course, there's a very significant number of children who are likely to be somewhere in the middle on that spectrum. So we needed to design our survey in a way to be able to gather that and to be able to relate those experiences along that spectrum to the risk of health and mental health outcomes across the lifespan. So on the next slide, you can see the aim of our analysis within this particular component of the study was to ask 4 different questions about different types of exposure to domestic violence. And you can see here those same 4 that I talked about earlier: physical assaults, threatened physical assaults, property damage, and coercive control. We also analysed data in relation to the association between a person's experience during childhood of exposure to domestic violence and mental health disorders, the same to that that we were talking about earlier, so depression and anxiety. And we want to understand the unique association that exposure to domestic violence during childhood has with mental health once we adjust for other experiences of child maltreatment. So let's take a look. Thanks, Nadia. So the first question: does experiencing domestic violence, exposure to domestic violence during childhood, predict depression? The answer is a clear yes, almost double the risk of experiencing clinical depression, so the same definition that Deevna was talking about. This is again focusing on the youth sample, so the young people aged 16 to 24. We have 3,500 representative of the entire population who answered their phone when our survey researchers called them up and answered the questions around not only their exposure to domestic violence, but all forms of child abuse and neglect, and a range of health and mental health outcomes. But as Deevna demonstrated with her data on neglect, we can see here that there are gender differences, that it was even stronger for females who in childhood experienced exposure to domestic violence, that they were 2.4 times more likely to currently be reporting in adulthood an experience of clinical depression. Slightly less for males, so 1.9 times the risk of clinical depression. On the next slide, though, we can see that the situation changes once we put in that really important factor, that many of these young adults will also have experienced other forms of child abuse and neglect throughout their childhoods. Once we take those into account, we found that for males, the association with clinical depression was no longer significant, but it remained significant for females, who are still 1.4 times more likely to have clinical depression in adulthood if they'd been exposed to domestic violence. Thanks. Next slide. We now turn to another of our key outcome measures, and that was anxiety. So again, the definition of anxiety here is the one that would meet clinical diagnostic criteria. So does childhood exposure to domestic violence predict adult anxiety, clinical levels of anxiety during early adulthood, 16 to 24 years old? The answer is yes. Again, more than double the risk, but some slight gender differences there. 2.2 times more likely to experience clinical anxiety in adulthood for females, 2.4 times for males. But as we see on the next slide, again, the situation changes once we take into account those other forms of child abuse and neglect. And we can see once we've controlled for those other experiences during childhood, the relationship drops away and exposure to domestic violence no longer is a significant risk factor for anxiety during early adulthood. And I think that's really important when we start thinking about the strategies that we have in Australia around preventing and responding to domestic violence, that we need to be thinking about not only adults' experiences, but children and what that means. And so we can see here that we need to be taking a more global perspective, because once we take into account other adverse experiences such as exposure to another form of child abuse and neglect, the situation really changes. So the next slide, thanks. So the key messages really are that exposure to domestic violence is associated with the increased chance of clinical levels of depression and anxiety for both males and females. But as I've said, once we take into account those other experiences of maltreatment, that link, that association between exposure to domestic violence and these mental health outcomes are less significant, or in fact non-significant. The one that was still important though was for females, the link with depression. So what does that mean? It means that exposure to domestic violence is likely to often occur alongside other forms of child maltreatment, and that co-exposure, if you like, to multiple forms of abuse and neglect is likely to be accounting for the significant relationships that we see with later mental health. On the next slide, I'm going to introduce now a slightly different topic. We had also, as part of our examination of exposure to physical abuse, looked separately at the concept of corporal punishment. And so I'm going to talk a little bit now around what we asked about and what we found in relation to that. So on the next slide, you can see the definition that we used for our question on exposure to physical punishment of children in the sample. So corporal punishment involves use by a parent or a caregiver of physical force to a child with the intention of causing pain but not injury. And that's how it differentiates from our questions around physical abuse. And it's also done for the purpose of correction or behavioural control. So let's have a look at our aims now on the next slide. What we wanted to do with this analysis was to try and identify the prevalence of young adults' experiences of corporal punishment during their childhood. and to also look right across the entire sample. So this point I'm going to be presenting a little bit of data that's not just the young sample, but it's right across all of the different age groups that we had in our 8,500 participants, their beliefs around the necessity to use corporal punishment as a parenting practice, and whether that's changing at all by the different age groups that we have. So thanks, Nadia. Let's go to the next slide, and we can see the data there. So we grouped together experiences of 4 or more instances of corporal punishment throughout childhood, and we can see here massive numbers. So 61% overall of the participants in our study, this is just the young people, said that they had experienced 4 or more instances of corporal punishment throughout their childhood. Some slight gender differences there, slightly more males, slightly less females, but not statistically significant differences there. So this tells us that it is common. It's common for young adults to have experienced quite recent childhoods where they were exposed on more than 3 occasions to corporal punishment as part of the parenting practices that their parents or caregivers have used. So on the next slide, let's see whether in fact the attitudes to the use of corporal punishment have changed at all. And you can see here there's a very strong decline. So the oldest cohort, the 65 plus, where we have 1,000 participants, almost 38% said that it was necessary to use corporal punishment as a part of parenting. And that just kept dropping and dropping and dropping as our participants got younger and younger. And so you can see the 16 to 24-year-olds, less than 15% of them felt that it was important to use or necessary to use corporal punishment as a part of parenting, even though 61% of that group had themselves experienced 4 or more instances of corporal punishment. So there's a real disjunction between what people are experiencing and their attitudes. And to me, that's a positive message around the opportunities for change. So let's just turn to this final slide before I hand back to Ben and just recap. So we know that corporal punishment in youth in Australia is common. It's only slightly more common in males than females. But that over time, Australians have become less and less likely to believe that corporal punishment is necessary. With very gratefully, we were able to demonstrate that very few young Australians believe that it's important. So that really tells us that the time is now to address the risk of young people being exposed to corporal punishment and its mental health consequences. So it's time to end physical punishment of children. And that is the slogan of a campaign that's being led by the Parenting and Family Research Alliance that a number of us who are part of the ACMS and of course NAPCAN is very strongly in support of. So that's it from me. I'd like to hand back to Ben now, who's going to wrap up with some ideas around opportunities for progress and for prevention. Thanks, Ben.
Thank you very much, Daryl. Thanks, Divna, also for those great presentations. And folks, you can see the broad span of findings that we've created, and we haven't even really touched on any of the key prevalence findings of the types of maltreatment, which are some of the headline findings. And obviously we've generated data about a whole host of other mental health conditions, such as alcohol use disorder, PTSD, and also the whole range of health risk behaviours as well. So you can get a flavour from what we've spoken about today about the range of evidence that we've generated and their significant implications for public policy. I'm just going to wrap up with a few minutes to draw attention to some key principles that might help move us forward as a country. And look, this is by no means an easy feat. Every country around the world grapples with this domain, even those that have given it more attention than others grapple with how best to prevent and respond to not just child maltreatment generally, but indeed each of the different types of maltreatment, because they do have some similarities, but they do have some qualitative differences too. So these are really difficult issues to solve, but we can certainly make some important progress. But to make progress in preventing child maltreatment, we need this evidence of the type that we've generated in this survey to inform better targeted approaches. So I'll just make a couple of points here and then we'll open it up to a discussion. Thank you, Nadia. So basically, our findings have shown that child maltreatment is indeed a national concern. And this is, in fact, consistent with some national policy recognition about the importance of doing better to prevent child maltreatment. So, for example, the National Framework for Protecting Australia's Children aims to reduce all types of child abuse and neglect. It seeks a national approach to early intervention and targeted support, not just for children, but for families, of course. And that's essential because so much child maltreatment does occur, not always from malignant intent, but for a whole range of reasons. And so family and parental support is absolutely crucial. It's also informed by evidence about the annual national cost of mental ill health and suicide. And this is not just related to child maltreatment, but we can get an understanding that child maltreatment does play a substantial role in producing this national toll of mental ill health. So the Productivity Commission in 2020 estimated the annual national cost of mental ill health and suicide at $200 to $220 billion per annum. So we can see the huge burden that mental health problems cause for the country, and child maltreatment plays a substantial role in contributing to that cost. We also see recently, for example, from a separate study, a national survey of mental health, that found what was called a shadow pandemic of mental disorders in 16 to 24-year-olds. So mental health conditions are not just something that occur later in life and that affect people in middle age and older age. Oftentimes, they crystallize in childhood and adolescence, and this is a prime period of life in which we need to take steps to prevent and respond to the causes of these health conditions, of which child maltreatment is a major one. So that National Survey of Mental Health found 40% of Australian 16 to 24-year-olds had mental conditions or mental health symptoms in the prior year, and that was conducted 2020 to 2021. Of course, the pandemic may have contributed somewhat to that, but still the underlying prevalence of those mental disorders in this country is massive and frankly unacceptable. Similarly, these policy recommendations are consistent with the Productivity Commission's recommendations to prevent and intervene early in life and early in ill health, and to provide better support for new parents and to support socio-emotional development of school children. So, you know, we have this broad policy acceptance that more needs to be done to support children and families. They're good policy principles, but the big challenge is how do we implement those? Thanks, Nadia. And this is by no means an easy feat. As I mentioned, it's a massive and complex challenge, but we can be guided by some broad, generally accepted, sound, robust approaches to prevention. And the key model that people recommend is the public health approach, which I'm sure nearly everyone here will be familiar with. We essentially need a blend of primary prevention at the whole population level, secondary prevention for groups at particularly high risk, and then tertiary prevention at the top of that little pyramid there after the event. And where communities and societies typically fall down is in not giving enough investment and attention to prevention at the population level, or to primary prevention, and then to secondary prevention as well. So what's needed is a massive sea change in investment and prevention, especially at primary and secondary levels. It's not enough to put the ambulance at the bottom of the cliff. That is a required part of a public health model, but it is only one part, and in fact, much more investment and effort needs to be invested at the primary and secondary level. But to do that, there are massive challenges. And of course, resources is one, resources and personnel, and that can be amplified in a country such as ours that has such a broad geographical spread where it's difficult to deliver and access services. So it is no easy feat. Also, we may need different approaches to prevention according to the type of child maltreatment. So it's not a one-size-fits-all approach to prevent each type of maltreatment, because some of them differ quite substantially. So for example, neglect is so much different from, say, child sexual abuse. So just one particular type of approach to prevention will not work for each type of maltreatment. We also know from the international field that in terms of really robust scientific evidence, there are few really well-proven primary prevention programs at the population level to prevent child maltreatment. Some of the best evidence that we do have shows that home visiting programs for new parents, especially in the postnatal period, can be of particular use in preventing maltreatment. But even those programs have limitations. They tend to be devoted to preventing certain types of maltreatment, but not necessarily all. So there's a lot of challenges even in implementing these kind of gold standard approaches to prevention. Thanks, Nadia. If we do take a public health approach, though, what might a holistic public health prevention approach look like? And there's a nice little model here that's been promulgated by a major international agency from a country broadly similar to ours. It's called the Thrives approach, which I think is a really nice, neat model that can capture some of the key domains of preventive activity. And there's 7 key domains here that a country or a society might well adopt in implementing a public health prevention approach in terms of child maltreatment. And the model is Thrives, and the Thrives model takes its first letter from each of these 7 domains. So first, training in parenting, and that can be not just postnatal, but prenatal. Second, household economic strengthening, and as Deevna was talking about before, that's particularly relevant, say, for neglect, but there may be further downstream influences on prevention of, for example, emotional abuse and physical abuse in particular. Third, reduced violence through proper, robust legislative protection and responses. Fourth, improved social and therapeutic services, and this is a big one. And this particularly goes to that secondary prevention domain. So for example, we need excellent, accessible, and cost-effective social and therapeutic services for those, for example, who have alcohol and drug problems or mental health problems. That is so important, and that is a major precondition to any successful public health model here. Fifth, we need, at the societal level, we need values and norms that protect children, not just from maltreatment in that kind of amorphous sense, but we need to get more specific. And some of the things that our study might generate are new understandings about the significance of some previously neglected or overlooked or underappreciated types of child maltreatment. So emotional abuse, for example, might be one where we need to develop our values and norms to better protect children and better interact with children, especially within the family domain. The 6th domain there is education and life skills, and this can occur, of course, at multiple levels. So not just for parents, although obviously for parents, but it can also occur even further back, so right through childhood and adolescence at school in terms of embedding and helping to form key life skills that are needed for parents and caregivers. And 7th, surveillance and evaluation. And there, surveillance is a technical term meaning measurement rather than, cameras on street corners or looking into the private sphere in an undue sense. Here we're talking about the measurement and evaluation of programs and lived experience through program implementation. Now, even with a robust model like this, it's not easy to develop, design, and implement. There's all kinds of additional challenges like access, geography, there's cultural considerations to take into account, and there's particular challenges and needs for certain marginalised populations or high-risk populations as well. So it's by no means an easy feat, but this is a model that if our nation is serious about taking this, about giving this the priority that it needs, this is the type of model that we can learn from and use. Thank you, Nadia. On to the last slide there. In terms of requirements for implementing a model like that, I thought it might be useful and kind of easy to put all this in 4 Ps to implement a holistic public health approach. We need political will, and that can be injected through social policy, but that requires investment. And people often say, well, look, we can't afford to do this. We don't have the money. Well, my response to that is we can't afford not to. If we have a mental health burden of $200 to $220 billion per annum, of which child maltreatment contributes a substantial share, and we have the moral imperative to better prevent child maltreatment anyway, we can't afford not to if we're to take ourselves seriously as a liberal democracy that respects people's rights to a healthy, safe childhood and to have a decent chance of a fair-going life. The second thing we need is public awareness and participation, and that can come through social norms. It can also come through institutions, and some of the most important institutions are the ones that a lot of you in the audience are members of. So the key sectors that provide services and support to kids and families and early childhood education and care, schools, health settings, they're absolutely crucial bulwarks for a public health approach and for support of children and families. The third thing we need is connected to those institutions. We need the practitioners in them to have the support they need so that they can do a good job of responding to child maltreatment where it happens. So we need their pre-service and in-service education. We need to support them in delivering trauma-informed responses, and we need good systemic policies in those sectors as well. And fourth, we need parent engagement. Parenting is just such a massive responsibility. It's the most important job anyone can do, but people need the support that's required to do a decent job of that. So across those 4 Ps, they obviously have implications for multiple different social systems as well across that public health model. But we're delighted to be able to engage with an audience such as you today. Thanks for listening to us. We look forward to further discussions with you next year in particular, hopefully on several occasions, to talk about our main findings and to tease out their significance for you and for other social systems. But there'll be continually important further analyses that we do, particularly to identify really high risk areas that might give us indications of where we can give priority in terms of prevention and response to certain types of maltreatment, to kids of certain ages, for example, and certain other high risk areas. So we really look forward to those further discussions. Thank you very much, Nadia, and I think we are going to come back to Rani now, who will take us through the Q&A part of the session. Thank you.
Thanks, Ben. And thank you all, Daryl and Deepna, for your presentations. Very insightful and so much to digest there, and some clear ideas forward with the Thrives model and the 4 Ps. I look forward to hearing the full results and like putting these findings into the context in next year. We've had some really great questions come through, and I just want to make sure we get through at least some of them. Ben, just really quickly, just briefly, if you could just kind of tease out for our audience. You started off by saying there is no clear or reliable evidence on child abuse and neglect in Australia at the moment, and this study is going to change that. Can you just explain really briefly what you mean by that? Why is there, what have we been basing our policies on to date?
Look, great question. Look, to date, what we have is we do have some data from, say, child protection agencies. So we've got data about cases of different types of child maltreatment that are notified to child protection agencies in each state and territory, and what happens when those cases or suspicions of child abuse and neglect are reported to them. Those agencies will assess those reports. In some instances, they investigate those reports, And in some of those investigations, they substantiate a finding of a type of child abuse or neglect. And so there we get some indication of officially substantiated cases of child maltreatment. But of course, that is the literal tip of the iceberg, because so much child maltreatment, the vast majority, does not come to the attention of government child protection agencies. And even many cases that do come to their attention are not investigated at all, or they're investigated but not substantiated, even when there might be maltreatment happening. So we have some idea of what types of abuse and neglect might be more frequent than others, but we do not have good evidence of what proportion of kids experience each of these 5 types of maltreatment. The only exception to that is the fact that there have been some studies done with random samples of Australians about child sexual abuse. And there was a study done back in 2000, which made some quite horrifying findings. But even that evidence is somewhat dated and didn't extend right through to age 18 as well. So we have, for the first time, as a result of our study, we've generated reliable data about the proportion of all Australian children who experience each of these 5 types of child maltreatment.
Thank you. Thanks for explaining that. And I guess a follow-on question is that you did mention the research would provide insight into who inflicts the abuse. And often in the child protection data, abuse is defined as, parental abuse. Do you have any information at this stage that you can share about that and how you've defined that?
We actually don't have that information yet, and that's because we haven't analysed that particular data yet. So we've had mountains of data to analyse, and our team has worked like absolute troopers for the last 12 months in cleaning this huge data set and analysing it to generate our preliminary main findings. But what we will be doing soon, Deepna's holding up some papers there. What we will be doing soon is looking at diving down deeper into some of these more nuanced topics. And that will be one set of analyses that we do in terms of who is it who inflicts these different types of maltreatment. Now, what I can tell you is that for 2 of the 5 types of maltreatment, we did not ask that. And that's because those 2 types, and that is neglect and exposure to domestic violence, those 2 types happen within the home. And especially for neglect, that's a family and type of household type of environment. It's not like, it's the father or the mother doing the neglect. It's simply a circumstance of the child's upbringing that's, in virtually all cases, no one's fault. It's more of a socially influenced environment. But where we did ask who were all the people who inflicted it, we did ask that for physical abuse, we asked that for emotional abuse, and we asked that for sexual abuse. And what I can also say there is, and this picks up on the point about some of the types of maltreatment being different. So for sexual abuse, anyone can inflict sexual abuse. So it's not just sexual abuse within the household. It can be within institutional settings. It can be within community settings. So we actually had 42 different types of offender groups or offender types for sexual abuse. But for emotional abuse, that was only assessed within the home, so emotional abuse by parents or caregivers in the home. For physical abuse, we assessed that by parents or caregivers within the home, but also by parent-like caregivers in institutional settings like schools. Right, yeah. So as you can see, there's going to be some very rich, nuanced data about that. And I think Deepna, brilliant Deepna, Deepna's just put in the chat a reference, a hyperlink to our article, our protocol article, which explains all of that.
Fantastic, because we have had lots of quite technical questions about the methodology and the ways that, you know, respondents were engaged. So that's really helpful. I guess one of the questions though that keeps coming up, and I do want to ask is, and any of you could jump in if you like, is how many respondents were interviewed that don't speak English? Were interpreters used in any of these cases? And, you know, just in terms of geographic spread, do we look at rural and remote, or, you know, that kind of spread? So just a quick.
Divna.
Yes, fantastic question. Yes, absolutely. We do look at rural and remote spread, and actually our data showed that we had kind of fairly representative, based on the Australian census data, rural and remote locations. We don't use interpreters, and so all of the participants did actually have to speak English, but we did have a fairly representative sample of non-Australian background people. So in Australia, I think it's about 35% of people are born overseas, and we had something around the same. So we did limit it to Australian people, and the reason that we did that is because so much work goes into defining the questions that we ask, and some of the questions are actually kind of existing measures, so we need to make sure that they're asked exactly the right way, and all kinds of things can change the interpretation of language across languages and translations. So we just felt it was more important to get an accurate assessment than to do that, and certainly we would like to do more of that in the future.
Thank you. A related question someone's asked, and is, you know, quite interesting, is if people were born overseas and answered the survey, and the abuse had occurred overseas, is that been identified, and, you know, what does that do to impact your results?
Good question again, and we thought about that very carefully. And one of the key principles of general survey research at the population level is you don't want to exclude people unless it's absolutely essential, and so we chose not to do that. We also adopted our colleague David Finkelhor's approach in this respect, so we didn't exclude those people. What we did is we asked people what their country of birth was. We asked those who were not born in Australia, at what age were they when they did move to Australia. So we will have, we had the capacity to analyse both the level of maltreatment that they might have experienced, and in most cases, whether they would have experienced it here. Nevertheless, the key take home there is that these people are now in Australia, they're Australians. Even if they experienced maltreatment in another country, say their country of birth, they have experienced that, and more importantly, the likely associated outcomes of that maltreatment will have accrued here, and therefore their needs accrue and exist here.
Thank you. Daryl and Divna, you both mentioned gender differences in the analyses, and, you know, for neglect and for exposure to domestic violence. A question is, was sex defined only as male and female, or were any other gender identification types considered? And also, what do you think might be, you know, some suggested, you know, hypotheses, or, you know, a way to understand what those differences might be alluding to, particularly with neglect and the impact on males? So either of you, if you want to jump in.
Shall I go first, Stephen? Yeah, look, it's a really important issue, and one that we grappled with as a team. And thankfully, we have got some of the most comprehensive assessment of gender and sexual identity in a population level survey that's ever been collected in Australia. And so we're going to be maximising that. We've already planned some further analyses to kind of break that down. What we've presented to you today was just the males and females, but we've got a significant proportion of respondents who didn't identify as either male or female, and we've got the full range of subcategories. So absolutely, we're going to be focusing on that and looking at both the relative risk of the different types of child abuse and neglect and differential outcomes across the lifespan for those who might not identify as male or female.
Excellent.
Stephen, did you want to talk about the reasons for that?
No, I mean, I think Daryl's right. We did include self-identified gender and self-identified sexuality, but it's very exciting. We're very excited to kind of have this data, both for the prevalence of different kind of sexual identities and different types of gender identities, which hasn't been done at all. And then, of course, as Daryl said, the impact and exposure of neglect domestic violence, exposure to domestic violence, and all the other types of abuse on those kids.
Yeah, I think one thing that has emerged already in what we've presented is that the impacts of a particular type of maltreatment has to be seen in the context of what other forms of maltreatment have also been presented. And it's likely that there could be gender differences in that, including not just the binary male and female, but other diverse genders as well, if they're exposed to a greater burden of different forms of child abuse and neglect, or in fact other adverse childhood experiences such as bullying. And we've got some great data on that we're going to be able to include in subsequent analysis. That might help explain some of those gender differences that we're seeing.
Excellent, thank you, and look forward to that more nuanced understanding as well. What a contribution, and good luck to the team analysing all this data. I guess one really kind of interesting question, because we're coming close to the end as well, is, you're all experts in this area. You've been working in this field for such a long time. Would you care to share with us, with the audience, what surprised you most about the findings so far? I mean, the ones that you can share with us, and what you think the implications for that might be. Like what has, engaged you the most? And we'll start with you, Daryl.
Yeah, look, I think the thing that surprised me was the receptiveness that our participants had to the questions, their willingness to participate, and our capacity to actually have a representative sample of the whole population. And while we're not talking today about the overall prevalence rates, I think that, when we look at other studies that are done, we're going to be able to see how ours makes a particular contribution to presenting the picture in Australia. And so that's really exciting for me, that we have this such a comprehensive set of data that's going to be able to be used by politicians and policymakers and practitioners who really want to understand, well, if I'm designing a service, let's say it's a mental health service, have I even thought about the fact that a significant proportion of my clients will have their own childhood experiences? Some of them will also be parents. Am I preparing them for, being the best parent that they can be? There's so many different messages that are coming out, and I suppose that's what excites and enthuses me about this work, even though it's a very distressing and, sad topic.
Thank you. Deevna.
Yeah, it's a tough one. I mean, obviously, other than the prevalence itself, I think probably there are two things. One is the overlap, is we tend to think of child maltreatment as isolated instances. We think about sexual abuse, or we think about kind of emotional abuse, but really, a lot of that kind of abuse occurs over time and co-occurs. And I think the impact of that is particularly striking. The other thing is how early and extended the impact is. So I was really surprised to see clear diagnostic criteria influenced by child maltreatment, because that's a pretty stringent threshold. And so we're seeing that from very early ages, from 24 plus. And then, of course, as we look over the age span, there are still patterns of relationships that emerge over that. So it's not that once childhood is over, it's over and the trauma is over. It's really, childhood maltreatment has an impact early, and it has a lasting impact. And it's not new, but it's really startling to look at that data and see the lives that are impacted by this.
Yeah. Ben.
Thanks, Rani. I'll echo everything that Daryl and Deevna just said. I think a couple of things stood out to me. One was, and this is similar to something Daryl said, but just how keen our survey participants were to contribute to this survey, even those who had experienced maltreatment and often, substantial maltreatment, were very happy to participate. They did not say that they had experienced distress, and they were really encouraging towards the team in terms of the outputs that we've generated. I think one of the other things that really took me aback was, and look, we were prepared for pretty much everything. We know the field well, but we did generate a finding that we haven't discussed today, but we did discuss at a symposium we gave in June in Melbourne. And this again was just from the 16 to 24-year-old participants. And this was about one of the health risk behaviours that we assessed. And if we're talking today in Child Protection Week about whether Aussie kids are okay, unfortunately, while a lot of Aussie kids are okay, a lot aren't. And we need to do a much better job of protecting them and responding to their needs. And the finding that I'm referring to here was actually about self-harm. We found that by age 24, 40% of females and 20% of males had inflicted self-harm. So 30% of our 16 to 24-year-olds had inflicted self-harm, and particularly high rates for girls. And when we looked at associations between self-harm and child maltreatment, they were very, very strong. Now, obviously, I can't say any more than that, but they were very strong. So this is really, really serious, and we need to do a much better job. And look, we're exceptionally grateful to everyone attending today and to NAPCAN for all its work and for supporting better prevention in this space. We need to do much more as a country.
Absolutely. Thank you, Ben, for that. I think what I'm hearing from all of you there is, and across the presentation, was really how much of abuse and neglect occurs across a continuum. And there's kids who are doing okay, and there's once-off occurrences, and then there's the really, layered sort of complex issues that we need to look at with the co-occurrence in particular. And I guess from NAPCAN's perspective as well, one of the things that I guess interests us and is something that we want to kind of make sure the sector's thinking about as well is how we communicate these messages, which I think comes up in your thrives around the social norms and the attitudes and how we're talking about these issues. And I guess there is a lot of nuance to what you're saying. So as a sector, as we do hear your final findings, we'll need to think about how we communicate about this so it's not misinterpreted in some ways about certain types of abuse not being as important as others, or the implications of all of that, and coming up with that sort of consistent and constructive messaging as a sector. So we look forward to working together on all of that, as well as unpacking all this rich data that you have collected, and look forward to hearing more in March for sure. And I know we've come to the end of our time, so I just want to thank the audience for giving your time today for this important discussion. There's lots more on the website that the team have thrown into the chat, so if you want to find out more about the methodology or to contact the team, there's contact details on that website as well. I do want to reiterate that this is not the end of the conversation. I hope that you'll take some of what we've learnt together today forward in your work, talk about it with colleagues, etc., and also come back for the next iteration of data sharing. NAPCAN will be posting the recordings on our website, so please come back to that if you want, but anyone who's registered will get an email. There's a short survey that pops up when you close this webinar. Do take the time to give us feedback. Let us know what you enjoyed or what you'd want to see in the future, or anything that you think you might be using this information for. It's really useful for the presenters and for NAPCAN to know that. And there is one more webinar tomorrow. Do have a look on our website if you want to sign up for that and come together to talk about the importance of hubs as a one-stop shop for communities, for families, and how we co-locate really great services and the evidence behind that. Please continue to support the campaign. Thank you so much, and thank you Daryl, Ben and Deepna for your time today.